Professor Filippo Maria Ubaldi is the Scientific Director of General Life, International Reproductive Medicine Network, more than 30 centers in Italy, Spain, Sweden, and Czech Republic, with academic degrees in gene obstetrics, in andrology, and reproductive medicine. Professor Ubaldi have a huge scientific activity, author and co-author of 205 scientific papers with Scopus Index of 53. He has been invited as speaker at more than 600 national and international congresses on the topic of reproductive medicine, member of the ISHRI Executive Committee during 2005 until 2009. He has been chairman of the 60th ISHRI annual meeting held in Rome in 2010. And 2014 and 19, he received the Italian National Specific License as full professor in obstetrics and gynecology. And at the present, he's the chairman of the Italian Society of Fertility and Sterility. I will say, he's the co-founder of Poseidon Group and a board member of Poseidon Group. After the Shanghai Protocol, he is the godfather of the dual stimulation.
Godfather.
For me, he's the best expert in duo-stim. Le terme duo-stim est en fait italien, le duo. C'est la touche italienne pour la double stimulation. Vous savez, Tunisien, il comprend un peu le français parce qu'il a passé quelques années à Bruxelles avec nos amis Christophe Bloquil, Devreuil et Christophe Bloquil. En Tunisie, Tunisian like Rai Uno, la Squadra Azzurra, et je vous ajoute une troisième chose que j'ai commencé à aimer, c'est les scientifiques italiens. Je vais nommer professeur Carlo Alvigi, professeur Filippo Mario Ubaldi, que j'appelle Filippo Marvelous Ubaldi, et Antonio Lamarca, parce que des gens, sincèrement, qui s'occupent de science, mais qui ont une très bonne manière de vivre la joie de vivere des Italiens. On le remercie pour sa présence. Et je vous donne la parole.
Thank you. Thank you very much for this very nice presentation. Thank you, my friend. Yes, La Squadra Azzurra, unfortunately, this year is not doing very well, but you know, we are 4 times world champion, and I hope in the next World Championship we will at least participate like one of the favorite teams. So after this very nice presentation, then I want to thank Merck for this very kind invitation to give a talk on new markers of success in medical assisted reproduction. And I'm going to start my presentation with, this is my disclaimer of my conflict of interest. And I would like to say that it is, there is no doubt that the measure of success in IVF, as stated by ISHRI, by ISRM, by ICMART, is the efficacy in terms of cumulative live birth rates per started cycle. No other measures of success in IVF. It's the efficacy. Efficacy means how many babies you can have per started cycle. And to improve, we will see the efficacy for cumulative live birth rate. It is of utmost importance. 2 things: the number of the oocytes from one side, and of course the age of the patients. But first of all, before thinking to the live births, to the success in IVF, we have first to think about the safety for the patients. And when we talk about the safety of the patients, we have to think about the efficiency of our treatments. The efficiency of our treatments means to reduce the drawbacks of our treatments. And the two most important complications in our treatments are the ovarian hyperstimulation syndrome and the multiple pregnancies. And all these two complications now, thanks to the breakthrough that have been obtained in the last 10 years in reproductive medicine, now it is possible to almost avoid these two complications, hyperstimulation syndrome and multiple pregnancies. So in patients at risk of ovarian hyperstimulation syndrome, it is mandatory. And if you don't do today, it is bad medical practice. It's considered bad medical practice. It is mandatory the use of GnRH antagonist protocol, agonist trigger, and the freeze-all strategy. And the second most important complication, the multiple pregnancies, it should be recommended, the single blastocyst transfer, trying to select the blastocyst with the highest chance to implant, either with time lapse, with assessing the morphology of the embryo that could have more chances to implant to give a live birth, or with preimplantation genetic testing for aneuploidies, or, and very soon, hopefully, with the non-invasive preimplantation genetic testing for aneuploidies. And all these informations helped with artificial intelligence very soon, that I'm sure, but of course it has to be proved, that the artificial intelligence, especially in our field, especially in the possibility to select the embryo that has highest chance to implant, I'm quite pretty confident that will give important advantages. So the main outcome in IVF is the efficacy in cumulative live birth rate. And when we talk about cumulative live birth rate, the most important issue that we have to consider is the number of the oocyte. And cumulative live birth rate, and this is demonstrated by many papers published since 2011, when the first paper was published in Human Reproduction from Sesh Sankara, that for the first time she demonstrated on using the UK register on more than 411,000 cycles. She demonstrated that the live birth on fresh cycles reaches the highest level when you retrieve between 10 and 15 eggs. Then we will see a plateau, and then a decrease with increase of the number of the oocyte. But this is on fresh cycles. When we talk about fresh plus frozen embryo transfers, so when we talk about cumulative live birth rate, the cumulative live birth rate continues to increase with the increase of the number of the oocyte that you can retrieve. And this is one of the several papers published. One of the most cited is the paper published by Nikos Politsos a few years ago in Fertile Sterile on more than 1,800 cycle. And then again here you can see the first one? Does it? Okay. And here you can see that the light blue bars is the live birth rate on fresh cycles, and it's like the paper from Sankara, you have a high chance to have a live birth between 10 and 15, and then plateau and then decrease. But the blue bar, these represent the cumulative live birth rate, then you can see that continuous increase with increase of the number of the oocytes that you can retrieve. And to try to maximize the number of the oocyte, you should try to use two things: the best strategy, the best protocol, and the best drug to try to improve the number of the oocyte. These two papers are very well-known papers, sponsored by Ferring, that are two prospective randomized trials, the MERIT one and the MEGASET. The MERIT published in 2006, that was included the agonist cycles, and the MEGASET included the antagonist protocols. Then you can see that in both papers, you will see that there is a reduction on the amount of gonadotropins that you can use if you use recombinant FSH compared to HMG. And there's a significant increase on the number of the oocytes that you can retrieve if you use recombinant FSH versus HMG. When you look at the live birth rate per fresh embryo transfer, not per cumulative live birth rate, then per intention to treat, there's no differences. But since you have more oocytes, you will have more embryos, and then therefore, if you consider like the aim of our treatment, the cumulative live birth rate, at the end of the day, you will have a significantly higher cumulative live birth rate. And this is a review of the literature of 5 prospective randomized trials, and out of these 5 prospective randomized trials, in 4 of them, either it was used the agonist protocol or the antagonist protocol, there's a better efficacy in terms of oocyte retrieved with recombinant FSH versus HMG. This is another prospective randomized trial published a few years ago in 2019 from the Dutch group that compared HMG versus recombinant FSH to obtain a live birth per fresh embryo transfers. And the authors, of course, but we know since many years, and the authors concluded that there are no differences if you use HMG or recombinant FSH to obtain a live birth per fresh embryo transfers. But if you read better the paper, and if you keep on thinking about cumulative live birth rates, then you can see that in the paper, in the papers, there's mean differences in the number of the oocytes retrieved of almost 2 oocytes. So 2 oocytes more you can retrieve with recombinant FSH versus HMG. And when you think about cumulative live birth rates in a center with a good cryopreservation program, then of course 2 oocytes more can make the difference. And then there is a less amount of gonadotropins that you can use per oocyte retrieved with recombinant FSH. So 200 international units with recombinant FSH versus 230 international units if you use for HMG. So the data that I presented were for normal responders, but what about high responders? There's another sponsored paper, prospective randomized trial, sponsored by Ferring again, the MEGASET HR group, that they randomly treated high responder patients, and you can see patients with an antral follicle count of 30, so very, very, very high antral follicle counts, and with these patients, it is mandatory, as I said before, the use of agonist trigger and freezole, and in this paper was not used agonist trigger and freezole. And then you can see from the results of this prospective randomized trial that the total dose of gonadotropin used was significantly lower with recombinant FSH, 525 international units less as a total during the total stimulation. The duration of the stimulation was significantly lower with recombinant FSH, and the number of oocytes retrieved were 7 more. 7 more oocytes retrieved with recombinant FSH, and 5 metaphase 2 oocytes more retrieved with recombinant FSH. And also look at the blastocyst number obtained. There were 3 blastocysts more. And 3 blastocysts more, if you do per-implantation genetic testing and you select the euploid one, means 50% delivery rate per single euploid blastocyst that you transfer. Of course, they reported a significantly higher hyperstimulation syndrome in the patients that use recombinant FSH, but recombinant FSH is more potent than HPHMG. And if in these cycles you were used agonist trigger and freezole, you would not have any single ovarian hyperstimulation syndrome. And if you consider that in this group of patients that are reported in this study, you did freezole, then we would have had 283 frozen embryo transfer in the HPHMG group and 321 frozen embryo transfer in recombinant FSH group. So this means that you will have 40 in this set of of patients treated, 40 embryo transfers more. That means at least 40% chance to have a live birth. Another tale that probably, or not probably, for sure you have heard, is that if you retrieve too many eggs, then the quality of the embryos that derive from those eggs are not good. And this is a tale. There are several papers addressing the competence of the blastocyst obtained, the chromosomal status of the blastocyst obtained, and then I'm going to show one of the most recent one, that this is a study performed on good prognosis patients in donors from Spain. And then you can see that if you increase the number of the oocyte that you retrieve, there's a significant correlation with the increase of the number of euploid blastocysts. And if you look at the figure on the right side, then you can see that the euploidy rate remains stable across the number of the oocyte that you retrieve. So this means that if you retrieve 10 oocytes in this young population of patients, you will have 60% euploidy rate. If you retrieve 20, you will have 60%. If you retrieve 30 oocytes, still you will have 60% of euploidy rate. And the euploidy rate is not influenced by the amount of gonadotrophin that you use. And this is one of other papers published. This paper was from 2017, published in Human Reproduction, but there are several others. And they compared the total dosage of gonadotrophins, less than 3,000 international units, between 3,000 and 5,000, and more than 5,000. And according to the class of ages, there's no differences in terms of euploidy. So the euploidy is the same either if you use 3,000, 3,000, 5,000, or more than 5,000 international units. The euploidy differs only according to the age of the women. And why it differs according to the age of the women? So this is an important data that we published. It's so important that we publish on Science. We published 3 years ago in September on Science, and we demonstrated for the first time. We knew on the blastocyst since at least 15 years, but we demonstrated for the first time that the proportion of aneuploid metaphase 2 oocyte is minimal between 20 and 32 years, and then after 32 years, it increases dramatically with the increase of the age of the women. And as you can see in this table is a table that reports on the frequency of chromosome abnormality in human blastocysts that have been analyzed by NGS, and more than 100,000 blastocysts. And this is a table that is included in an editorial paper published on the occurrence of 40 years, celebrating the 40 years of IVF, published in 2018 in Fertility and Sterility. And you can see that the more oocyte that you retrieve, the higher will be the chance to find at least one euploid blastocyst. And this is particularly true with the increase of the age of the women. And in our country and in European countries, the mean age of the women in our centers is now more than 38. So in our center, 55% of the women are older than 40, and 85% are older than 35. So we have to deal with this population of patients. And dealing with this population of patients, how can, that with reduced ovarian reserve and with an increased aneuploidy of the oocyte, how can we try to maximize the oocyte, the number of oocyte? What could be the strategy that we have to apply to try to maximize the number of the oocyte? So we said that the critical outcome of IVF is the efficacy in terms of cumulative live birth rate per started cycle. But what about if we change the paradigm? And we use as a paradigm the critical outcome for IVF is the efficacy in terms of cumulative live birth rate per ovarian cycle, not per started cycle, but per ovarian cycle. And this paradigm we changed already in poor responders, but as you will see, we are going to change also in normal responders. So in poor responders, we can maximize the oocyte healed per ovarian cycle with the dual stim strategy. And after the introduction of the double stimulation concept by the group of Shanghai, the Wang, then we proposed in 2016 in this pilot study 2 conventional stimulation in the same ovarian cycle. And in this pilot study of 51 patients, we wanted first to demonstrate that the competence of the oocyte coming from the second stimulation, from the luteal phase stimulation, was exactly the same as the competence of the oocyte coming from the first stimulation. And this is the protocol, the original protocol, and the protocol that we are using for the dual stimulation is 2 conventional protocols in the same ovarian cycle for poor responders. From 2016 till today, we have published more than 15 papers on the dual stimulation, trying to demonstrate all the possible application advantages and disadvantages of the dual stimulation. Also, you will see a paper on the newborn with the blastocysts coming from the luteal phase. And what is constantly observed, and I'm sorry that I did not include it in this set of slides, some unpublished data on more than 2,000 cycles of dual stim that we performed. And in all the papers published, we demonstrated that the number of metaphase 2 oocyte that we retrieve in the second stimulation is significantly higher than compared to the first stimulation. And because the fertilization rate is the same, then the number of the embryos of the blastocysts is higher, and the competence of these blastocysts is exactly the same. So at the end of the day, since the number of the oocyte is higher, the fertilization rate is the same, the number of blastocysts is higher, the euploidy rate is the same, the number of euploid blastocysts will be higher. And what is clinically relevant from this concept is that if you compare the patients that concluded per started cycle the dual stimulation, they will have 65% of this couple will have at least 1 euploid blastocyst to transfer. And this is significantly higher if you compare with those patients that did only the conventional stimulation, the follicular phase, that, as you can see, is 42% of them will obtain 1 euploid blastocyst. But maybe the most important advantage that we have with the dual stim is the significant reduction of the dropout. So this paper was published a couple of years ago in Fertility Sterile in a selected patients, not poor responders or poor prognosis patients, but Bologna patients. So those patients that fulfill the Bologna criteria. And then you can see that there are 2 different groups of patients, one that agreed to do the dual stim, and the other group that agreed to do the 2 conventional stimulation. Then we observed that, of course, by definition, the dropout was 0 with the duostim because they had to do two back-to-back stimulation in the same ovarian cycle. And the dropout of those patients that failed the first conventional stimulation was 90%. So of those patients that failed the first stimulation, 90%, only 10% repeated the second stimulation. And then another important data is that the time between the two oocyte retrieval. It's 15 days, 16 days in the dual stimulation, and is 141 days in the two conventional stimulation. And if you look at the live births, ongoing pregnancy rate, and live births per intention to treat, then you can see that there's a statistical trend. It's 15% in the dual stimulation and 8% in the two conventional stimulation. Last year, in the ESHRE, and the paper is in preparation, Juancho Velasco demonstrated that in a prospective randomized trial, that if you use two conventional stimulation versus dual stim, you will have a significantly reduction time to obtain a euploid blastocyst. This year, there was a paper presented as an oral presentation by Nathalie Massin that did not reproduce this data, but the scheme of the duostim was completely different. They used in the oocyte freezing, and they did not use the blastocyst freezing, so they did not succeed to report this data. So this is the paper that we published a couple of years ago in Human Reproduction on the obstetrical and perinatal outcome of the babies born from blastocyst transfer from follicular phase and from luteal phase. This is the clinical results, and were absolutely comparable. And you can see that the birth weight and the gestational weight were comparable. There were no differences on the pregnancies and the babies born from blastocysts obtained from the follicular phase and the blastocysts obtained from the luteal phase. But this was quite, obvious, because all the data that I presented, and there are many others, but there's no time to show all the data, regarded the poor prognosis patients. But what about if we change the paradigm also in normal responders? So what about if we consider the critical outcome for IVF, the efficacy in terms of cumulative live birth rate per ovarian cycle in normal responders? And who is a normal responder? Normal responder, according to the definition of Sesh Sankara and Antonio Lamarca, is those patients that retrieve between 4 and 15 oocyte. When we think about this group of patients, we have to take into consideration several issues. More than 80%, at least in our countries, of our patients are older than 35. In our centers, 85% are older than 35. Oocytes have a higher meiotic aneuploidies, between 50 and 90%, according to the age of the women. It's 50 in patients of 35, is 90% in patients of 42, 43 years. Less time available for conception, so they have to try to shorten as much as possible the time to live birth. And these patients, some of these patients, would love the strategy one and done, the strategy that was proposed by the Boston IVF group a few years ago in Fertile Sterile. So we can try to rethink about our aim during an IVF treatment. Our aim is not to make embryos and to put the embryos closing our eyes in the uterus, but we have to decide to full personalize the treatment for the patients that we have in front of us, and then to decide whether to start again or not the second stimulation according to the number of the blastocysts, the embryos that we obtain, and the age of the patients. But to do this, we have to be very clear in our mind that if we have a patient in front of us, 35, the embryos that she will produce, they will be 50–60% euploid. And this doesn't mean that you have to test. Either you test or not, 50–60% will be euploid. At 38, 30–40% will be euploid. At 40, 20–30% will be euploid. At 43, 10–20% will be euploid. So you have your patients, you have the number of blastocysts that you obtain, and then according to the number of blastocysts that you obtained and the age and the probability that in those number of blastocysts that you obtained, they will be the euploid one, you will decide whether you go for transfer or to start again the second stimulation. And another important issue is that also in normal responders, the blastulation rate, it depends on the quality of the gametes that we have. So the blastulation rate is not the same in all circumstances. So the mean blastulation rate that we have is about 30%, but it could be 40% in very good prognosis patients with good seminal samples, and it could be 10–20%, and we demonstrated in a paper that we published a few years ago in Human Reproduction, in severe male factor infertility. So also these issues, these aspects are important to take into consideration. So let me take some examples. We have 3 women, one of 35, one of 38, and one of 42. Normal responders, 8 oocyte, 10 oocyte, 12 oocyte. The first one, she obtained 2 blastocysts. The second one at 38, 3 blastocysts. And the fourth one at 42, she obtained 3 blastocysts, although she retrieved 12 oocytes. So at 35, the euploidy rate is 50–60%. So it's, I have good chance to find the euploid one in the 2 blastocysts. And in these patients, in this case, I don't need to go for a second stimulation. The 38-year-old woman, she has 3 blastocysts. The euploidy rate is 30–35%. So again, I have good chance to find in that bunch of blastocysts the euploid one. And then I do not need to go for a second stimulation. In the third one, she will have 10–20% of euploidy rate, and with 3 blastocysts, my chance to find the euploid one is very low, so it's better to start again a second stimulation in order to make 3 more or even more blastocysts, and then per started cycle, because the time unit is the started cycle, per started cycle, I will have more chance to find the right blastocyst for transfer. But look at this second example. 35-year-old woman, 12 oocyte, and so not absolutely not indicated according to the early indications of duostim in poor prognosis patients. 12 oocyte is a good number of oocyte retrieved, but she had a very poor semen, testicular spermatozoa, and she made 1 blastocyst. So this 35-year-old woman, although is 12 oocyte, but the chance to find the euploid one in 1 blastocyst is low, then she has to undergo a second stimulation. Also, with 6 oocyte 2 blastocysts, again, it will be profitable for them to go for second stimulation. But look at the 42-year-old woman. 7 oocyte retrieved, 42, so it's not a lot. But she has a fantastic blastulation rate. She obtained 5 blastocysts. So the chance to find a euploid one in 5 blastocysts is high. So although 42, although 7 oocyte, she does not need to undergo a second stimulation. And we demonstrated this concept, because this was a theoretical concept, but now you have to demonstrate scientifically. And we demonstrated this concept in these very recent publications, few months ago, in JARC. And then in those patients, in these couples, that retrieved less than 3 blastocysts. We propose to undergo either the dual stimulation or 2 conventional stimulations. The second conventional stimulation had to be performed within 1 year. What we observed, again, an incredibly high dropout rate. So you can see that the dropout in the conventional stimulation was 90%. And the cumulative live birth rate was 12% for those patients that decided for the 2 conventional stimulations versus 24% in those patients that decided for the dual stim. Of course, these differences, it's not because there's some secret recipe in the dual stim. There's not. It's only that you avoid the dropout. And avoiding the dropout, then you rescue the pregnancies that you will lose with the dropout. But look at what's happened also in those women that delivered. In those women that delivered with the 2 conventional stimulation, there were only a minimal part that had 1 more euploid blastocyst to use. And in the dual stim, almost half of the patients that delivered, they still have euploid blastocyst to use for a second attempt, for a second live birth. So let me conclude that the cumulative live birth rate per started cycle is the measure of success in IVF. The oocyte number and the age of the patients are of utmost importance. We must try to maximize the oocyte number with the right drug, with the right controlled ovarian stimulation strategy. Recombinant FSH significantly increased the oocyte number compared to HMG. But first, the safety for the patients, we must reduce the OHSS risk, and we have to use generate antagonist protocol, agonist trigger, and freeze-all strategy. And we have to reduce the multiple pregnancy, and we should try to transfer a single blastocyst. We could change the paradigm from cumulative live birth rate per started cycle to cumulative live birth rate per ovarian cycle, as we did already in the poor responders with the dual stimulation strategy. And the dual stim reduced the time to find euploid blastocyst, reduced the dropout, and there's no differences in obstetric and perinatal outcome after follicular phase stimulation or luteal phase stimulation derived blastocyst single transfer. We could change the paradigm also in normal responder, especially when the advanced maternal age is in front of us patients with an increased rate of meiotic metaphase 2 oocyte aneuploidies. The blastulation rate could be different amongst different couples, and it can be influenced by age of the patients and by male factor. So we could fully personalize the control of ovarian hyperstimulation and decide if to apply the dual stim strategy, starting the second stimulation according to the number of blastocysts obtained after the follicular or the luteal phase stimulation and the age of the patients. This personalization could then maximize the cumulative live birth rate per ovarian cycle also in normal responder patients. I thank you for your attention.
Thank you, Dr. Ubaldi. Je tiens à vous dire qu'on va prendre 2 questions et que le docteur Ubaldi est disponible pendant la pause café pour répondre aux questions relatives à l'exposé ou aux questions diverses concernant la PMA. I say that...
Yeah, I understand.
Okay, I understand.
I spent 4 years in Belgium.
You agree because you have questions until tomorrow.
Yeah, no, until this afternoon because I have to leave.
So, première question, on va commencer par l'aîné, Bedis Chanoufi.
Hello, Monsieur Ubaldi. We are welcome. You welcome here in Tunisia. Delighted to be here with us. I understood that your strategy is to maximize the number of oocytes retrieved. I mean, those cumulus oocyte complex. And I would like to ask you, in this strategy, what do you think about the fact of adding a recombinant LH the cycles, I mean day 1 or day 6, 7, to maximize the number of oocytes in cycles when you have a hypo-response. I mean in the group when you have normal responders. I would like to avoid the cases when you have hypo cases or poor responders cases. I mean hypo response in normal responders cases.
Okay. So the question that you made, it means that you read and you studied very well the paper from Carlo Alvigi, the meta-analysis that he published in Fertile Sterile, where he demonstrated that FSH plus LH, can be used to all patients, but has a significant impact in certain categories of patients. And the category of patients that has a significant value in terms of number of the oocytes and probably also in terms of the quality of the embryos obtained are exactly the categories of patients that you said. So I tell you that in more than 80% of our cycles, 80, we use FSH and LH, recombinant FSH and recombinant LH. We have the injector in Italy, and then this is very also comfortable for the patients. And why 85%? Because 85% of our patients are older than 35. And amongst these, the vast majority are also poor responders. So in poor responders or high poor responders, if you use the FSH and the LH together, starting from day 1, not from day 6, because this has been demonstrated by Ernesto Bosch already back 10 years ago in a prospective randomized trial that he published in Human Reproduction. Starting from day 1, then you will increase probably the quality of the oocyte and also the number of the oocyte that you can retrieve in this category of patients.
C'est Dr. Mahmoud, Khalid Mahmoud. Oui, la question suivante.
Thank you for this nice presentation. I would like to ask you, is there practical criteria, ultrasound or other criteria, for identify the best candidate for duostim?
At the beginning, because of course you have to explain all the possible strategy to the patients before starting the treatment. If you start the treatment and then on the day of oocyte retrieval or on the day of the blastocyst, the number of blastocysts that you have, then you go to the patient and say, okay, now we start again the second stimulation. Then the patient said, what are you doing? So at the first consultation, you have to tell the patients all the possibility of the strategy that you can apply. And at the beginning, we used to say to the patients, especially in advanced maternal age with an antral follicle count, let's say, of less than 10, we said that, look, probably it could be a good strategy to do the dual stimulation. And, but in this group of patients, so advanced maternal age more than, let's say, 39, 40, with less than 10 oocyte, in about 80%, you will go for a dual stimulation. But in 20%, you do not need really to go for a dual stimulation. So at the beginning, we did dual stim also in some patients that probably did not need to go for the dual stimulation. And when I started to present the dual stimulation concept, the most criticism that I received at the congresses was that who tells you that you are doing a second stimulation that is not needed? Because if you retrieve, for instance, 4 blastocysts at 35, and these patients had an antral follicle count of 5, and then you decided to go for the dual stimulation because she had an antral follicle 5, and from these 5, she obtained 4 blastocysts, this is not needed, a second stimulation, because the chance to find euploid one is very high amongst those number of blastocysts. So we modified the strategy, and we decide to apply in a more personalized way the start of the second stimulation according to the probability to find a good blastocyst according to the age of the patients, independently from the number of the oocytes that you retrieve. Because we do the dual stimulation even in patients with 15 or 16 oocytes retrieved. But if they have a 1 or 2 blastocysts, and if they are 42, then of course the chance to find euploid one is very poor. So it is better to maximize for the time unit the chance to find euploid one. So now the criteria to decide whether to do the duostim or not, it's not anymore at the beginning of the treatment, but at the end of the treatment.
Alors, la dernière question, oui.
Professor Ubaldi, for your presentation, for coming in Tunisia. I know this is your first time here.
Yeah.
So I have a short question. In the duostim, in the practical question, in your duostim, after the follicle phase, and on the retrieval oocyte day, did you pick up all the oocytes, or did you let the small ones for another stimulation yet? Depending on the size of the follicle, the day of the retrieval day.
So you know that this question is the most popular question. And, but this question, so we retrieve everything. We retrieve also 11 millimeters. So after one oocyte retrieval, there's no any more follicles available. And the basis on the dual stimulation or the triple stimulation, because I mean in patients for fertility preservation for cancer patients, we do 3 stimulations also. It has been published recently, a paper for 3 stim for fertility preservation. I was in the Middle East, and then a guy said that he does 5, 6 continuous back-to-back stimulation. So once you trigger, then those follicles are not anymore available, are not anymore good. So those follicles go to atresia. It's a continuous recruitment of follicles. So every day, there's batches of new follicles that are available. And then when you start, so why don't you have a second ovulation in the luteal phase? Because you have progesterone that keeps FSH low. But also in the spontaneous cycle, and this is the example of the luteal stimulation. If you start in the luteal stimulation giving FSH in the spontaneous cycle, then you will have all the follicles that are in the luteal phase that will grow. So it's the second stimulation, it's not the follicles from the first stimulation, but are new follicles. And those new follicles will start their growth after the complete demise of the corpora lutea. So this is why you should use the agonist trigger in the first stimulation, because if you use the ACG, then the age effect on the corpora lutea, the old corpora lutea will stay longer, and then you will only use more days of stimulation. Nothing happens. I mean, you can give drugs, but if there are corpora lutea, then the follicles cannot go. So the follicle will start growing when the corpora lutea will go away.